Hi everyone, this is Renee. In this voiceover we're going to cover tuberculosis. Tuberculosis is also referred to as TB. Tuberculosis is an infectious disease that is caused by Mycobacterium tuberculosis. Lungs are usually the most commonly infected organ, but any organ can be affected by TB. TB is the primary cause of death worldwide, and it is also the leading cause of death in patients with HIV and AIDS. There are greater than 2 billion people infected with TB worldwide. Okay, so there are many risk factors for developing tuberculosis. These include being homeless, being a resident of an inner city neighborhood, being a foreign-born person, living or working in institutions, and this includes healthcare workers, IV injecting drug users, poverty or poor access to healthcare, being immunocompromised, and being of Asian descent. These all put you at risk for developing TB. Okay, so there's different classifications for TB. The classifications for TB include primary infection, and this is when the bacteria is inhaled by the infected person. There's latent TB. This infection is when the person is infected but does not have the disease actively. And then active TB disease is either primary TB or reactivation of TB, which happens after the client has had the primary infection. Clinical manifestations of TB. So clients with latent TB infections are going to have a positive skin test, but they're going to be asymptomatic. If the client has pulmonary TB, it will take about 2 to 3 weeks to develop symptoms. Initially, they'll have a dry cough that will become productive. They will have fatigue, malaise, anorexia, weight loss, a low-grade fever, and night sweats. Dyspnea and hemoptysis are also some late symptoms that they will have. So continuing with the clinical manifestations of pulmonary TB, in the later stages, these clients are going to have a cough that becomes more frequent. It is very common for them to have dyspnea or shortness of breath, and they will also develop hemoptysis, and this is usually associated with advanced disease. Now, some clients with pulmonary TB can also present more acutely. They can have a high fever, chills, generalized flu-like symptoms, pleuritic pain, productive cough, and adventitious breath sounds. One of the diagnostic test studies for tuberculosis is the tuberculin skin test, or TST. You have all probably had this test. It's also called the Mental test. What this test does is it uses a purified protein derivative, PPD, which is probably how you guys recognize it. And this is injected intradermally and usually in the forearm. We will then assess for induration of the site in about 48 to 72 hours. Presence of induration, not redness, at the injection site indicates development of antibodies secondary to exposure of TB. Another diagnostic study for TB is a chest x-ray. The only problem with the chest x-ray is we cannot make a definitive TB diagnosis solely off of the x-ray. And there's 2 reasons for this. The first is that the client with TB may have a normal appearing chest x-ray, and the other reason is that other diseases can mirror TB on a chest x-ray. Some findings on an x-ray that do suggest TB include upper lobe infiltrates, cavitary infiltrates, and lymph node involvement. These will all suggest TB if seen on an x-ray. Another diagnostic study used to test for TB is the interferon gamma release assay blood test. This blood test is used to test for interferon gamma release from the T cells in the bloodstream. So basically, this test aids in the diagnosis of TB. The nice part about this test is that it's more reliable compared to the chest x-ray to tell us if TB is what's causing the infection in our client. This test can also differentiate between latent TB and active TB infections. Okay, so the last diagnostic study we're going to talk about for TB are the bacteriologic studies. These are required for diagnosis of TB, and what they are 3 consecutive sputum samples that we collect on 3 different days, and they are then sent for culture and smear. The stained sputum smear are examined for acid-fast bacilli, or AFB. If the AFB is present, then it is indicative that the TB is present in the body. The culture results can take about 8 weeks to come back, but usually if the suspicion of TB is high in the patient, treatment is warranted and will often be started before we actually get these culture results back. So for collaborative care, clients with TB do not usually require hospitalization, although hospitalization may be needed for severely ill or debilitated clients, but generally they can be treated outpatient. Now, if a client has a positive sputum smear, they are generally considered infectious for the first 2 weeks after starting treatment. As the nurse, we want to educate the clients while they're contagious to restrict visitors, to not travel with public transportation, and to try not to make trips into public spaces. Drug therapy is also used to prevent or treat active disease. Our role as the nurse is to monitor for compliance with these patients. Because drug therapy is the only way to treat TB, we really need to make sure the clients are taking their medications and that they're becoming, or they are, compliant with their treatment regimen. Drug therapy for active TB is very aggressive treatment. There is a 4-drug regimen that will be used, and it will be done over 2 phases of treatment. The initial treatment phase is going to be 8 weeks, and then the continuation phase is about 18 weeks. So directly observed therapy, or DOT, was created because of the non-compliant risk factors that a lot of these clients have. What happened was clients were not taking their medications, and it was creating multi-drug resistant tuberculosis, which is even harder to treat. So DOT involves providing anti-tuberculosis drugs directly to the clients and watching as they swallow the medications. This is actually the preferred strategy to ensure adherence to the medication regimen. Generally, public health nurses at clinic sites are the ones who administer this type of therapy. DOT is actually very expensive, but it's essential because of how much of a public health issue TB really is. And there's a huge risk for reactivation of TB when clients do not complete the full course of therapy. So there is a vaccine to prevent tuberculosis, and this is the BCG vaccine, and this is used to prevent TB in parts of the world where it is very common. In the U.S., it's not recommended except for select individuals like healthcare workers who are often in contact with clients with multi-drug resistant tuberculosis. With this vaccine, it is a live vaccine and can cause a positive PPD reaction. So the nurse's role when completing an assessment on a client who may have TB includes collecting a history. So we're going to ask them about a previous history of having TB. Have they been around anyone with TB recently? Any chronic illnesses they may have? Or if they're on any immunosuppressive medications. We're also going to ask about their social and occupational history, and that's going to help us determine their risk factors for transmission of TB. We're also going to do an assessment of their physical symptoms. So we're going to ask them if they've been having a productive cough, night sweats. Have they had any afternoon temperature elevation, any weight loss or pleuritic chest pain, or any abnormal lung sounds? Because all of these are going to be signs and symptoms of having tuberculosis. And then we want to collect some sputum from them. And the best time to collect sputum from a client if they have a cough is actually going to be early in the morning. So these are just a few nursing diagnoses that we can give to the client with TB. So ineffective airway clearance, ineffective breathing pattern, non-compliance with that medication regimen, and this is a big one with clients with TB, and ineffective self-health management. So planning and outcomes for our clients. So the client will comply with therapeutic regimen. The client will have no recurrence of the disease. The client will have normal pulmonary function. And the client will take appropriate measures to help prevent the spread of the disease. Okay, so our nursing implementation for this client are going to include acute interventions, such as airborne isolation. So we want a single occupancy room with 6 to 12 airflow exchanges per hour. We also want healthcare workers to wear high-efficiency particulated air masks, HEPA masks. We also need immediate medical workup for these clients, and appropriate drug therapy must be in place. So we really need to educate our clients on preventing the spread of TB. So we need them to cover their mouth and nose with tissues when coughing, sneezing, and producing sputum. We need to educate them on the importance of coughing and sneezing into their elbow and not into their hands. This is a big one you're hearing a lot right now, I'm sure. They need to wash their hands frequently, especially after handling sputum or soiled tissues. The client needs to wear a mask outside of their negative pressure room. And we need to identify and screen any close contacts to the patient.